Good afternoon, everyone. It's Tom here. I'm here to do your afternoon weekly ITU teaching, and today's subject is going to be cations and the heart, in brackets, arrhythmias. So it should take about 20-25 minutes-ish, and it should be hopefully quite informative. It's a fairly interesting subject, I think, anyway, and hopefully you will find it relatively interesting as well. So without further ado, let's start. So the scope. So we'll start off by talking a little bit about the anatomy and the physiology of the heart and the conducting system. Hopefully take you back to medical school, first, second year of medical school. We'll talk about the potassium homeostasis, a bit about calcium, and also a bit about arrhythmias. So the reason that I wanted to talk about this was because I think it comes up quite a lot in intensive care, and I don't know about anyone else, but often I just sort of I don't find it as enjoyable when you treating something without knowing exactly what's going on or why you're treating it. And I think we all roughly have a vague idea as to what is going on at a physiological level, but it's good to sort of update and upgrade and just double check we know what we're talking about. What I'm not going to really be doing is talking too much about the detailed management of them. There's a lot of arrhythmias and proformas and Rhesus Council things, and they're open access to anyone. Hopefully this is going to go a little bit deeper into the forgotten knowledge that we have about this, provide a bit more of a theoretical understanding, and maybe a few clinical nuggets along the way. Obviously it can't be really interactive, but there's a few questions as we go along that I'll sort of pause for a few moments and you can have a little chat amongst yourselves or have a think about what the answers might be. And maybe if you want to pause it at 10-15 minutes in and have a break and stretch your legs and stuff, that's absolutely fine as well. So the structural features of the cardiac muscle. So just going to talk particularly about the conducting system and not about anything else. So there's the cardiac muscle cells, or cardiomyocytes, are specialized into three different types of cells. You've got the pacemaker cells, the conducting cells, and the contractile cells. So the pacemaker cells are just specialized bundles, and they basically form the SA node, sinoatrial node, and the AV node, atrioventricular node. Going on from that is the conducting cells, and they're responsible for basically conducting the action potential down, and then the contractile cells are the ones that function to contract and to eject blood from the heart. So a little bit about each one. The pacemaker cell has a special quality called automaticity, so it generates the action potential itself. And that basically means that if your heart is cut off from its autonomic supply, it will still generate a heartbeat. And the heart rate that it generates differs as to where those pacemaker cells are. So for example, the SA node would generate a heart rate of 60 to 100 beats a minute, the AV node about 40 to 60, and the Purkinje fibers would generate a heart rate of about 20 to 40 beats per minute. So while the pacemaker cells have automaticity and they have their own special action potential that doesn't involve the plateau phase or anything like that, the conducting cells have a special quality called rhythmicity, and they basically are responsible for the heart contracting as a single unit, also known as a functional syncytium. And finally, you've got the contractile cells, and they're the striated muscle cells, and they overlap when they contract to shorten and to eject blood from the heart with a stroke volume of about 70 mils per beat. So zooming in a little bit, we having a look at the microscopic anatomy of the heart. So here we have a few cardiac muscle cells. They are nucleated with mitochondria. If you can see in the top left, there's an intercalated disc, and that is a junction between the two cells. And inside those discs, lined along them, they have something called desmosomes, which keep them together, and gap junctions. Gap junctions allow calcium to pass from one to another to propagate the action potential, and they basically ensure that the heart muscle contracts all in one unit all together to eject the maximum amount of volume or stroke volume with each beat. Moving on, as I said, we have nuclei in these cells. They're striated, so they have a similar appearance to skeletal muscle cells. They have their actin and myosin binding sites, and they overlap each other, and they're all related to the Starling forces. And the more that they're stretched, the more that they will contract up to a certain point. And if you remember your Starling chart, there's a point where they are overstretched. There's no longer any overlap between the actin and the myosin, and the stroke volume starts to tail off. The other thing we've got is this sarcotubular system. So these blue squiggly lines are T-tubules, and they're a extension of the exterior of the cell deep into the cell. So they allow calcium to move down them and then to move across into the cell as part of the propagation of the action potential. And on to the next one. So cations. So part of this topic is about cations, so we should probably cover exactly what they are. I'm sure it's back in everyone's knowledge somewhere what they are, but let's just go over it one more time. So we've got a cation, and that is an atom or molecule in which protons outnumber electrons. So it is basically a positively charged ion. If you remember, we've got negatively charged ions, which are called anions. What are the four most important cations? So if you can have a think and have a little discussion, or just think in your head. So maybe it's open to debate, but these are the four I've got: sodium, potassium, calcium and magnesium. And why are they important? Well, they regulate the action potential, and if there is an imbalance, they can cause arrhythmias and affect contractility. So we've got a number of different ions, negative and positively charged, that exist intra and extracellularly, and each has a propensity to exist either inside or outside of the cell. These are rough numbers, they may not be exact, but as you can see, they balance osmolality on both sides, and they maintain electrical neutrality. So extracellularly we have sodium, chloride and calcium, and intracellularly we have potassium, magnesium and phosphates. So going into the electrophysiology of the heart and what the ion channels do. So we've got to think about what keeps them inside and outside the cell, and what drives them, for example, potassium to be intracellular and sodium to be extracellular. So each ion is trying to exist in something called electrochemical neutrality. And they move down their gradients in a chemical way, so from a high to a low concentration, while trying to maintain a electrical neutrality. And the addition of all these varying equilibrium potentials between each ion, if the addition of those together forms the resting membrane potential. So this is basically the electrical charge of the interior of the cell relative to the exterior. So a charge of minus 90 millivolts, for example, would be saying that the inside of the cell is 90 millivolts less in charge than the outside of the cell. And as I said before, each ion has its own specific equilibrium potential, but it's the relative membrane permeability of each of these ions that determines its overall contribution to the resting membrane potential. For example, potassium is much more permeable than sodium, so it makes a bigger contribution to the net membrane potential. So now we've done a little bit about the physiology of ion channels, we can move on to the action potential. So the action potential it's crucial to understand this, as this forms the understanding of which antiarrhythmics in the Vaughan-Williams classification work, and also what different cations and ions in general do to the integrity of the heart, the contractility, and the propensity for it to develop an arrhythmia. And this is the crux of the whole talk, really. So we'll take a little bit of time going through this. So just describing what we can see here. So we can see time on the x-axis and membrane potential in millivolts on the y-axis. It's divided into 5 phases. So you've got phase 4 on the bottom, 4 on the floor, and then 0, 1, 2, and 3. So going from left to right in the chart, we have phase 4, which is known as the resting phase. And the resting potential of the cardiomyocyte at this point is 90 millivolts, and this is due to a constant outward leak of potassium through something called inward rectifier channels. At this point, sodium and calcium channels are closed, and they're just trundling along here. At phase 0, so we've done phase 4 here, and it's minus 90 millivolts. At phase 0, we start to get an influx of sodium. So an action potential is triggered by a neighbouring heart muscle cell, and a small amount of calcium moves through the gap junction, and that makes because calcium is positive, it makes the resting membrane potential slightly less negative and more positive. Now, if the stimulation is strong enough, we'll reach something called the threshold potential, and that's about minus 70 millivolts, and that's demonstrated by the top blue dotted line. So if there's enough stimulation, you reach something called the threshold potential, and that is basically the charge, the voltage at which a action potential will continue on its own without the need for further stimulation. Yeah. Once this threshold potential is reached, we get a rapid depolarization, talking a couple of milliseconds at the most, and that is a huge influx of sodium. So if we remember, sodium is extracellular, the sodium channels open, and there's a huge rush of sodium inside, and that makes the membrane potential positive, because you're getting an influx of sodium. And then we get to the top of phase 1, the rapid influx of sodium. At this voltage, approximately about positive 20 millivolts, there's a voltage triggered ion channel that opens, and this is a potassium channel and this channel is just triggered by the voltage 20 millivolts for some reason, and that starts an efflux of potassium, because potassium is the main intracellular cation, so it starts to move extracellularly down its concentration gradient when its channels open, and that starts the repolarization phase. However, specific to a cardiac muscle cell, we get this phase 2, which is a plateau phase. And the reason this plateaus is because there's a sudden influx of calcium at this new voltage. So the influx of calcium balances out the efflux of potassium, and then you get this sort of middle ground where they're both doing opposite actions, so you get no change in the voltage, and it's roughly around 0 millivolts that this continues for. And this lasts for about 200 milliseconds, and this is known as the refractory period. The refractory period is the sort of section of the action potential that another stimulus couldn't cause another action potential and another beat, and this is the thing that protects us against arrhythmias. And this is a thing that if you've got a imbalance of certain cations, then it overcomes this, and you can develop something like ventricular fibrillation, for example. These eventually close once it's exhausted, and potassium continues to do its work, continues to leave the cell, and phase 3 is just the continuation of the repolarization phase. And if you look at a ECG tracing, that would be the T wave of the ECG, and we get back to our phase 4 on the floor resting membrane potential. So we're about halfway through now. We've done all the anatomy and the physiology, and we're getting on a little bit more into the clinical side of it and particular effects of each ion. So this is a good chance to have a little recap as to what we've been talking about. So if you want to pause the video now, stretch your legs, have a drink, and then come back to it, feel free to do so. Right, so if you've had a break, we will go on for a little recap now. So just 4 questions, just to test whether anyone is actually listening. So we've got the first question, which is, should be coming up. Name the subtypes of the heart muscle. So, can anyone name the 3 subtypes? I'll give you a few seconds. And the pacemaker cell, the conducting cell, and the contractile cell. The buzzwords are automaticity, rhythmicity, and functional syncytium. Can we define a cation? I'll give you a few seconds. A positively charged atom or molecule. Name 2 predominantly intracellular ions. Potassium and magnesium. And lastly, can we remember how many phases there are in a cardiac action potential? And the answer is 5. So I wonder if anyone got tricked there, because 0 is one of them. So 0, 1, 2, 3, and 4. And if you remember, it's at phase 4 on the bottom. 0 going up is a depolarization. 1 is the start of repolarization. 2 is the plateau phase, where calcium is doing the opposite effect to potassium, and then phase 3 is the continuation of repolarization, and that's the T wave. So, talking about potassium now, everyone's favourite subject. So, what do we know about potassium? So it's the principal intracellular cation, and it's the main determinant of resting membrane potential. I don't know why I've put. Oh, sorry, yeah. Extracellular potassium is the main determinant of resting membrane potential. So what I mean by that is that if you've got a high extracellular potassium, that closes the gap between the intracellular and the extracellular, so it reduces the membrane potential. And if you've got a low extracellular potassium, that increases the gap between the intercellular, which is high, and the extracellular, which is now low, and that increases the resting membrane potential, making the difference bigger and more negative. Okay, if that makes sense. So what else do we know about it? So it is transcellular, the transcellular gradient is maintained by that fateful sodium-potassium ATPase pump, which pumps 2 sodiums out of the cell for 3 potassiums to come into the cell. And this is probably the most one of the most important enzyme channels in the body. Potassium is intrinsically linked to the sympathetic nervous system. Beta-2 agents, agonists, they increase the activity of sodium-potassium ATPase, and we'll go on later to remind us how salbutamol works in that respect. And lastly, but I'm sure potassium has many other functions, but it helps regulate acid-base function. So if we think that often in acidosis you have a hyperkalemia, why is that caused? So potassium essentially buffers hydrogen ions, so it will exchange, it will go extracellularly and take hydrogen intracellularly in an acidosis. So that's why you get a high potassium in acidosis. So you start to develop clinical features of hypokalemia at below 3.5 millimoles per litre, and it gets really severe if it's below 2.5 millimoles per litre. And these severe symptoms, you will start to get skeletal muscle weakness, and that's because if you remember the effect on increased on resting membrane potential, if you've got a low potassium, that's a larger difference between the inside and the outside of the cell. So you've got a hyperpolarized cell membrane. So if you think it's further away from that threshold potential, so you need a higher stimulus to reach that threshold potential to generate an action potential, which makes the muscle weak because it doesn't work as well. And then in the cardiac muscle you get arrhythmias, QT prolongation. I remember a mnemonic that I discovered a while ago. I don't know if it's a mnemonic or a song, I'm not sure, but it's sort of, you have no pot and no ST, but a long PR and a long QT. But it's always helped me remember it, so you can have that one for free. And then, so hyperkalemia is the opposite, so you get increased extracellular potassium, which increases the resting membrane potential from 90 millivolts, minus 90 millivolts, to minus 80 millivolts. So it moves the resting membrane potential close to the threshold potential, meaning there's a smaller stimulus required to generate an action potential. This makes it more excitable. So in hyperkalemia, you have a more excitable cardiomyocyte, hence a propensity towards arrhythmias. So what are the clinical sort of features of hyperkalemia? So it's most likely that below 7 millimoles per litre, unlikely to get arrhythmias. And it's all dependent on how quickly the potassium escalates. So arrhythmias are much more likely if you have a rapid increase in potassium rather than a gradual one. And like hypokalemia, you also get ECG changes, and these are peaked or tall tented T waves, an absence of P waves, a wide QRS complex, and the possibility of asystole. And if you have a serum potassium of over 6, it's strongly recommended that monitoring is applied to the patient. So how do we treat hyperkalemia? So we come across a lot of this in ITU, and there's three ways to treat it, and it depends on the severity of symptoms and how quickly the potassium increases. But if you're concerned about any ECG changes at all, then the first thing to do would be to stabilise the membrane, and that is by using calcium chloride. So what that does, it increases the threshold potential. So although the hyperkalemia has raised the resting membrane potential towards the threshold potential, then the calcium just steps the threshold potential to keep it the same distance away from the resting membrane potential, meaning that you need the same level of stimulus to produce a action potential. And the dose for that is 10 mils of 10% calcium gluconate. So the next thing that you do is promote potassium to shift into cells. So that can be done a number of ways. We normally do that with insulin, so we give insulin dex, so 10 units of insulin, 50 mils of 50% dextrose. And what that does, it activates the sodium potassium ATPase pump, as I said before, to kick 2 sodiums out and get 3 potassiums into the cell. Another way to do this is beta 2 receptor stimulation. You've got beta 2 receptors also activate that pump, which is why salbutamol works. But the only thing is, salbutamol takes quite a bit longer than insulin. So the other way to promote shift of intracellular potassium is sodium bicarbonate. So this only works if there's a concurrent metabolic acidosis. If the bicarbonate is normal on the blood gas, then this probably won't work. So the way that works is it increases intracellular sodium, which then activates the sodium potassium pump. It does have there's some debate about whether or not to use it. Some studies have said that it takes too long to work, but the studies that I've seen have only really involved one study only involved hemodialysis patients, and I guess how long it takes to work is how quickly you infuse it. Note that it's not particularly clear how quickly you give it. You give 50 mils of 8.4%, but the speed at which you give it is dependent on a few different factors, and there is an equation that you can find to figure that out. But invariably, when I've seen it, it tends to be made up a bit. And then lastly, you can try and get rid of or excrete potassium from the body. So hemodialysis is the quickest way, but it's costly. We've got easy access to it in ITU, but on the wards, obviously, they don't have it. Or we can use exchange resins, so calcium resonium, and I think that's about 30 grams that you give, and you can repeat that every few hours, every 4 or 6 hours, I think. And that's another option, although I've never really seen that used much. So we've got about 6 or 7 slides to go. So on to hypocalcemia now. So calcium affects the membrane stability. It doesn't have a direct effect on the resting membrane potential, but as we spoke about earlier, it does lower the threshold potential, so increases excitability. Causes, so mainly in ITU, critical illness is the main cause of hypoalbuminemia. Often there's no need for calcium correction, but if you just optimize the nutritional status, then the calcium should improve. Other causes are vitamin D related, so it may be dietary intake or malabsorption. Parathyroid related, so hypoparathyroidism will cause hypocalcemia. And things like acute hypophosphatemia, excessive citrated red blood cell transfusion, as that binds to calcium, and also tumor lysis syndrome. So be careful if people are with cancer are having radiotherapy. So key features of hypocalcemia: so altered mental status, Chvostek's sign, which is the one of where facial muscles are contracted on tapping of the facial nerve. Trousseau's sign, which is the carpopedal spasm, which is elicited by inflating an arterial blood pressure cuff above the systolic pressure. And other symptoms that you can get is hypotension, laryngospasm, which is important to anaesthetists, and cardiac arrhythmias. Oops. Sorry about this. And the main ECG changes you'll get is a QT prolongation and a V conduction block. So hypercalcemia is only becomes symptomatic if it's severe, so if it's above 3 millimoles per litre. It enhances contractility, which is called inotropy, but also hypercalcemia can impair relaxation, which is called lusitropy. So relaxation of the heart muscle is actually an active process. ECG changes you'd get here would be a short QT interval and a widened T wave. So on to magnesium. So magnesium is a bit of an enigma of a iron. It's not exactly sure. No one knows exactly how it works, but it is vital to many functions in the body. So it's a cofactor in most ATP-mediated reactions. So it's very important for cell metabolism, DNA synthesis, protein synthesis, and many forms of cell homeostasis. It's involved in the Krebs cycle, energy metabolism. So it's a bit of a big player around the body, which is why it's so important in the management of arrhythmias. So specifically to the heart, so it's essential in pumping and controlling sodium, potassium, and calcium movement across the cell membrane. It increases both intra and extracellular magnesium concentrations. Increases in both intra and extracellular magnesium concentrations have inhibitory cell on the T and L type calcium channels. So the T and L type channels are used in the pacemaker action potential, and also in excitation contraction coupling, which is sort of the mechanism of cell contraction. So the causes of hypomagnesemia are inadequate dietary intake, malabsorption states, gastrointestinal losses, bowel resection surgery, and the overuse of diuretics and laxatives. So essentially, a lot of ITU type related causes and issues, which is why I guess we see a lot of low magnesium and a lot of arrhythmias. So when do we use magnesium? What are the indications for it? So we use magnesium in cases of hypo. So magnesium is essential for the function of the sodium potassium ATPase pump. So without it, that pump doesn't work. Therefore, you don't get the intracellular shift of potassium, so you get a low intercellular potassium, but also at the kidneys they fail to excrete potassium, so you get a hypokalemia as well. So if you've got a hypokalemia with a hypomagnesemia, you must remember to treat the magnesium before treating the potassium, because otherwise it won't work as well. The other thing it exacerbates is digitalis toxicity. So digoxin works by inhibiting the sodium potassium ATPase pump. So if you got it doing that, and then the the hypomagnesemia doing that as well, that has a summative effect and exacerbates the toxicity. In terms of specifically the heart, which is what we're interested about, it's essentially an antiarrhythmic. It can be thought of as a calcium channel blocker, really. It reduces the automaticity via the effects on the pacemaker potential. It also increases nodal conduction time, so it slows AV node conduction, and at the SA node as well, it slows that automaticity down, and it increases the refractory period by the sort of inhibitory effect on calcium. And also blocks accessory pathways, so it's useful in sort of nodal arrhythmias, atrial arrhythmias, and ventricular. So it's a little bit of a like a domestos of treating arrhythmias. So just it's very important to realise that often when you're faced with an arrhythmia, one of the best and the easiest thing you can do is treat and correct the magnesium. So the other thing that magnesium can be used for is as an antihypertensive agent. So it works at the endothelial level. It sort of exchanges and activates various interleukins and NO and various other things to vasodilate to reduce the blood pressure. And also theoretically, it has a role in cardiac ischemia. So it reduces coronary artery spasm. It reduces sort of the myocardial demands, but studies so far haven't really supported its routine use in acute MI. So I haven't really got round to doing a conclusion or anything yet, but essentially what we've been through is sort of a recap of the anatomy and the physiology of the heart conducting system and action potentials. We've had a look at potassium homeostasis and how to manage particularly hyperkalemia. We've had a look at the role of calcium in arrhythmias, and also had a look at the role of magnesium, and especially how we can use magnesium to our advantage in the ITU and clinical settings. I've included a terribly written reference list there, but feel free to have a look at any of those, or I can send you the links. And have a look into it further yourself. So hopefully this has been fairly useful, and hope you enjoy the rest of your day. So that's goodbye from me, and thank you very much. Bye bye.